Okay, welcome everyone to another day of the Pandemic, Science and Society. Our first speaker today is Dr. Shanna Kattari from the University of Michigan School of Social Work. Sorry about that, I was overthinking your first name. Dr. Kattari will be talking to us about the impact of COVID on disability and ableism and on trans and non-binary people. Welcome, Dr. Kattari.
Thank you so much for having me. I'm really excited about this. I see some questions coming in already, but I have taken the advice of your fearless leader and organizer, and we'll probably be doing questions at the end. And maybe I'll answer some of them as we go. So we'll see how that is. Welcome to Zoom. Just because of some of my certifications, I have to have a declarations page. There's a black and white picture of Oscar Wilde in front of a multiple shades of purple background, and the text reads, "I have nothing to declare except my genius." I have nothing to declare as far as competing interests. However, I do want to know, I'm a community engaged scholar, community focused scholar, have been a community organizer and activist. And so in creating this presentation, in addition to more traditional peer review and other white paper type citations, I also reached out to members of disabled, chronically ill, queer, trans, deaf, hard of hearing, and other communities to ask what they wanted to make sure that I shared and said. And so I really want to thank all of those folks, neurodivergent folks too, for making sure that this presentation encompasses what the community wants folks to hear. Who am I? I'm Shanna Kattari. I know it's one of those names. I always like, Mom, you couldn't have chosen a name that people could pronounce. And I use she and her pronouns or my name as pronouns. I have a master's in human sexuality education from Widener University and a PhD in social work from the University of Denver. I'm currently faculty at the University of Michigan School of Social Work, Department of Women and Gender Studies, jointly appointed there. And I also am the director of the Sexuality, Relationships, and Gender Research Collective. The type of research I do, I kind of have like interlapping Venn diagrams of circles. So I do research on disability, ableism, and microaggressions kind of in one circle, sexuality in one circle, and then also queer and trans experiences, especially around healthcare and affirming healthcare access. And of course, those overlap around sexuality and disability, around ableism and trans folks' experiences of healthcare, etc. I think it's also really important to center who I am as I'm speaking up in this space. So I'm a queer, disabled, chronically ill, neurodivergent, middle class, also fat, cisgender, white, Jewish femme. And that's who I am as I show up in this space. So I'm going to have that positionality in how I speak and share what we're going to talk about today. Also, I saw some folks mentioning in the Q&A, I'm fairly active on Twitter, so you can follow me on Twitter or live tweet anything that you're hearing, whether you agree or disagree. And my Twitter handle is Dr. Shanna K. I'm also on TikTok as Dr. Femme, if you're a TikTok kind of person. So as we get started, I want to talk a little bit about disability, people with disabilities, and language. And there's an image on the screen. It's a 3x4 grid of smaller blue and white squares, and each of the squares depicts a different type of disability or impairment. So there's a wheelchair user, there's somebody walking with a cane, there's signs for not seeing, not hearing. There's also a pregnant person, because interestingly enough, in the United States, being pregnant is considered a short-term disability, which oftentimes people are not aware of. And you'll notice that I alternate back and forth between using people with disabilities and disabled people. And so since over a quarter of people in the United States report having a disability or impairment or medical condition of some sort in that way and identify as having a disability, you can imagine that with a quarter of the population, there's a lot of disagreement and different language options that people use. So for a long time, people were using language around disability that was like things we would consider like really offensive now, the R word, handicapped, please don't use that, don't use handy-capable, any of those things associated with that. And in the early 90s, mid 90s, the disability community was like, you know what, let's use person first language. And so person first language is you put the person first. So it is a woman who is in a wheelchair. It is a man who is on the autism spectrum or who has autism. It is a non-binary person who is blind, right? So you're putting the person ahead or separate from the disability, right? And that was pretty radical for the time that it was. And like many things, it took the human service professions and the healthcare professions a while to catch up on that. And so by the time that started being really popular in the late 2000s as like the right way to talk about disability, and I put right in quotation marks, the disability community again was like, hey, there's actually two problems with this concept of person-first language. The first comes out of the social model of disability, which posits that society is what disables us, not individually. So if I'm a wheelchair user, me being in a wheelchair isn't the problem. If we had a society that had, well-paved sidewalks, curb cuts, no stairs, working elevators if there are stairs that are always working, all of those things, it wouldn't be a problem, right? So it's not the disability that's the problem, it's society. It's society that disables us. Similarly, if I'm a blind person and everything is in Braille or, screen reader compatible or available via audiobooks, right? People are using image descriptions in all their presentations. Again, my blindness isn't the problem, right? It's society that makes it a problem. And so for many people, identity first language, being a disabled person, is because we're saying that society is what is disabling us. On the other side is also the fact that we don't use person-first language for almost any other identity. We don't say a woman of lesbian tendencies, please don't say that. We say a lesbian woman. We don't say a man of blackness or of Black history. We say a Black man. We don't say a non-binary person who happens to be tall. We say a tall non-binary person. So it's actually really ableist inherently to say that the disability is so bad, so problematic that we want to separate it from this identity rather than just seeing it as a natural facet of human diversity. So you'll notice through this presentation that I use both person first and identity first language. For myself, I prefer identity first language, as you might have noticed during my introduction. But in general, some people prefer person first, some people prefer identity first. And so I use both when I present to try and be as inclusive as possible. And when I say disability, impairments, medical conditions, this spans the gamut, right? So acquired are things, I didn't get my arthritis until I was 12. That was not congenital. Congenital is what you have when you are born, right? So some folks are born deaf or blind. Some folks are born with heart issues, those type of things. There's visible and non-apparent disabilities, right? So for those of you who are able to see me, as you're looking at me, I don't, quote, look disabled. And if you were able to see me in person, depending on what context you saw me in, I would still probably not look disabled, depending on whether or not I had a cane with me. And that also doesn't even account for things like chronic illness, right? So some people have very apparent disabilities and some people have non-apparent ones. There's also short-term versus long-term. I went to undergrad in Colorado, and let me tell you, the number of students that were always on crutches from going skiing for the first time was astronomical, versus folks who have permanent or long-term disabilities, right? But both of these groups of people still experience ableism and needing access. There's some people divided into these very clear categories of physical, learning, intellectual and developmental, and socio-emotional or psychiatric disabilities. There's also this idea is often like, oh, what is your disability, as if there is one, but oftentimes they're concurrent and comorbid with other types of impairments or differences. So someone might be blind and also be anxious, or someone might be neurodiverse and also be a wheelchair user. You'll notice that deaf and hard of hearing is somewhat separate from this. So many deaf people do not consider their deafness to be a disability or even an impairment. They speak a different language. They speak ASL, and so it's more of a language difference. If everyone learned how to speak ASL, it wouldn't be a problem, right? And similar for many folks who are hard of hearing. That being said, historically, and also in a lot of, in research in access to accommodations, deaf and hard of hearing folks are often linked into the disabled or disability category. And chronic pain and chronic illness are kind of these outside perspective. They've always been on the fringes. Disability justice movements are like, we are all welcome. People who experience chronic pain, absolutely. You're meeting the same ableism, the same challenges with not having access and accommodations that we are. Same with chronic illness. But also what's interesting is often chronic pain, and sometimes chronic illness is more likely to affect feminine presenting people. and is often seen as less of a, quote, real disability, which I think can be tied in with some like deep-seated misogyny about like you should be able to suck up the pain. It's not really something that's challenging. But I think especially now in the age of COVID, things like chronic pain and especially chronic illness are really coming to the forefront of this conversation around health disparities amongst disabled people, really challenges with having to isolate, quarantine, access to care, especially folks who are immunosuppressed and are unable to be out and about. So when I say disability, it includes all of this. All right, so now we're gonna get into I've tried to like put them into groupings, and some of these again are from peer-reviewed sources, some of these are from nonprofits and research groups and think tanks, and some of these are from community members. My last page of all of this has a whole bunch of references, and I've let Krista know that she's welcome to share this with any of you. So first of all is the rationing of care. And I saw early on before I even popped on some questions around this, and I actually wrote a piece for the National Center for Institutional Diversity that came out early this summer about the ableism inherent in a lot of the COVID narrative, especially around rationing of care. So there's a lot of discussions about who deserves to have access to a ventilator or an emergency department bed when they run out of space, right? And especially, for example, in New York, we saw early on, there weren't enough ventilators, there wasn't enough space. And so triage looks really interesting. And several states, including, for example, Kansas, put out these kind of standard operating procedures around, triaging care. And a lot of them were really ableist. So they came from this idea that if someone is already chronically ill, particularly, for example, if they have cancer, like we shouldn't try to save them first because a ventilator could go to a, quote, younger, healthier person. There's also a lot of conversation about intellectual and developmental disabilities, but not using that appropriate language, sometimes even using the R word. And, how they should be lower on the list of who gets saved first. There's also a lot of conversations about what quality of life looks like, and this idea that certain people look or are healthy and others are not. And so then we create this false hierarchy of, what does healthy mean? And this is where my disability studies, comes off, is that if someone's a wheelchair user and that's, quote, the only thing wrong with them, does that make them inherently more or less healthy than someone who has the same blood pressure, the same cholesterol readings, the same oxygen saturation as someone who's not a wheelchair user? Then there's also this issue that Alice Wong writes about. She is a woman who's a wheelchair user and uses a ventilator on a regular basis. And, this idea that her life, because she's already on a ventilator, is somehow less valuable than somebody who only needs to be on a ventilator for a short period of time is really challenging. So there's a lot of debate. A lot of the states that had put this into their standard operating procedures moved back those languages or got rid of them once people were talking about them, but some states still do have them on the books. So as we see more hotspots and emergency departments getting flooded, ICUs getting flooded with new COVID cases, there's a really big concern about the ableism in who deserves and who should be able to access care. There's also, this has happened in a lot of spaces, not just around disabled folks, but in general, this fear of going to healthcare providers and emergency departments because of fear of getting COVID. Totally valid fear, but what has happened is that a lot of people haven't gone in cases of real emergencies and real illnesses and real need. And so what we don't really have access to is this kind of unintended consequence of only come to the medical spaces if you truly need it, and how many people have become severely injured, severely ill, or even died because of the lack of trying to seek care. Also, many necessarily medical procedures were delayed for months. An example I can give is I have severe migraines. I take medicine every night, medicine every morning. I take a shot at home. I'm on monthly by myself. And then I also go in once every 3 months to get shots at my neurologist. And I was supposed to get them April 15th. So you can imagine that was pushed back. And in Michigan, we really continued to push back non-essential, and I use that in quotations, services over and over again. So I actually wasn't able to get my needed shots until the next quarter, so July 13th, which meant I had a 6-week long migraine. which meant I couldn't work. I could not engage with the people I loved. I could not watch TV. I couldn't read a book. I just sat in bed with ice packs, trying not to throw up all of the time. There's also shortages of medication. So this is coming out more and more now as people were stocking up with things. But also, production slowed down, especially in some of the areas where we're getting our medications from. And also were being used to save people in the emergency department, but really lowered the quality of life for people who took them regularly. Also, this was compounded by the miracle cure, and again, in quotation marks, suggested by our president for COVID, and more keep coming out. But one of them was used by lots of lupus and rheumatoid arthritis patients. And as the president touted this unproven cure that turned out to not be effective at all, many of these patients were unable to access their medications. In fact, in California, they were told, physicians were told not to give, and pharmacists were told not to give it to the existing patients and to save it for COVID patients. And so it wasn't even a real shortage. It was this created shortage in response to that. Resources have also really changed. So a lot of public spaces being closed or are open but don't have restrooms leads to folks who are out and about having accidents, inability to take medication, etc. So for example, we're pushing people, go outside, go to the parks, and I'll talk about the access of that in a moment. And the parks are open, but the restrooms aren't, right? Or you need to go out to the grocery store to get needed food. And the restrooms aren't open. And so a lot of disabled folks, including folks who are experiencing homelessness, have relied predominantly on public restrooms to use the bathroom, but also to take their medication, to have a quiet space free from panic attacks, which can also be triggered by masks. And those are no longer available in many spaces. Accessible housing has historically been incredibly challenging to find, really difficult to get into. And now that many more people are experiencing economic disparities, there's even less accessible housing that exists, and there's more of a fight to get into the existing spaces. Additionally, a lot of chronically ill people work from home because that's what they need to do for their bodies and their minds. But now they're competing with non-disabled people from these work from home opportunities because more people are wanting to work from home, and there's larger rates of unemployment. Also, I was talking before about medication issues, but also lots of people with disabilities use things like Clorox and Lysol wipes to wipe things down and keep things sterile. They use rubbing alcohol to be able to take their daily injections. And when everybody was suddenly, obsessed with finding wipes, which you still can't really find in most places, and then people were trying to make their own hand sanitizer out of rubbing alcohol and aloe vera. For months, there was an inability to get these resources, which means that a lot of people didn't have access to their daily care or to be able to do their daily care safely. People were, trying to wash down their leg with soap before giving injections to themselves. Something that also comes up is this feeling of being disposable. So there's obviously a lot of debate. I'm sure you've been hearing about this. And you probably know it for yourself about should we try to just open everything up and go back to normal? But the fact that we're even having that conversation without an effective tested vaccine means that lots of people with disabilities, chronically ill folks, are being left behind. There's this rhetoric that's happened since the very beginning and continues to happen of only 1% to 2% of people who get it die, and it's only the older people and disabled people who die. And that rhetoric is really ageist, it's really ableist. This idea that some lives are more valuable than others is actually eugenics, and really problematic, and yet it is in every regular conversation. You turn on the news, you open up Twitter, that's what we're seeing. And so when people call that out, the response is just stay home. And that's being told to many disabled and chronically ill folks, which is already really challenging. I will say I have not been outside of my home and my partner's home other than to go to the emergency department and my physician's office since March 11th. Right? So I am staying home, but if the idea is we're just going to try and develop herd immunity through making everybody sick and then the disabled and chronically ill people can come out, means that I might be staying inside my house for 2 to 3 years. And that's really an unfair ask to make of people. Additionally, because many of folks in this population have already been isolated and homebound because we don't have enough accessible resources to support people in independent living, even outside of the pandemic. The anti-mask rhetoric can feel and truly is life-threatening. You know, people saying, I don't want to wear a mask, I don't care. The reports of people, you know, hugging folks without a mask, kissing them or spitting on them. You know, I think we've all seen probably those news stories, is really terrifying and creates this fear and this idea of like, you're seeing my body as disposable. Also this having this interesting tension of having to prove that you're in a high risk category, right, in order to access accommodations, in order to be able to work from home, but then also being viewed as disposable by society. And so you're having to like prove like, yes, I am at high risk. And then they're like, well, since you're at high risk, just stay home and like, we never want to see you again, right? There is this also interesting tension of finally gaining this access to accommodations. So disabled folks have been asking for a whole smorgasbord of accommodations forever, right? But for a long period of time. So some examples include working from home or being able to do virtual learning from school. So if somebody is having a flare or, you know, a PTSD incident, being able to, you know, Zoom into a classroom, even if the class is in person, having flexible hours. So, you know, someone with chronic fatigue being like, instead of 9 to 5, I'd like to work, you know, noon to 9. Is that doable? And being told that that's not an option. Having captions in things like Zoom, for example, having asynchronous options. All of these things people have asked for and have often been turned down, of saying, you're not going to work as effectively if you're at home. Flexible hours means you can't connect with the people you need to connect with. Captions, like our platforms just don't do that. All of those things. And yet, almost overnight, but really in a week or two, still working on captions with Zoom, this happened, right? Which is positive in some ways, right? I say this as a chronically ill person. Being able to take Zoom calls for faculty meetings, sitting on my couch with an ice pack and a heating pad and a cup of tea is like delightful. And also it's really harmful and frustrating to our mental health as disabled people that things we've been asking for, that we physically and emotionally need to be successful in our environments and have been told no over and over again. It's too much money, it's too hard to make happen, you won't learn as effectively, happened so quickly when non-disabled people said that they needed it. It also forces disclosure if people aren't comfortable. So as an example of faculty going back to teach in the fall, many universities put forth this thing that said, if you are over 65, if your weight is this category, if you have one of these CDC related illnesses, you can request to teach online. But many of them required documentation for that. And even the ones that didn't, if you're not 65, and, you know, simply by saying I need to teach online based on my health issues is forcing people to share their diagnoses, or at least the fact that they are chronically ill, even if they don't want to. And given the history of ableism in our country, and especially in employment, there's a big fear that that's going to be used against people in the future. Mental health is a huge thing. I think you've heard about mental health in a lot of other spaces, but COVID has been a huge trigger for people with OCD and anxiety, as I'm sure you can imagine, folks particularly who are already focused on washing their hands over and over again, you know, and in cleanliness, you know, wiping down groceries, having to wash your hands, being told to do that constantly can create this very pervasive mental loop. Folks with anxiety, obviously, I think we're all anxious in general, but if you have an existing anxiety disorder, that's really flaring up for a lot of folks. Having to stay at home increases depression and anxiety, but also feeling at risk because you're out and about and might get COVID increases depression and anxiety. People are feeling really isolated. Understandably, again, everyone is, but especially for folks that are being told, like, just stay at home until this is over, and that's in quotation marks again, we won't know what that looks like. That's a lot. So a positive, because when I say impact is not always negative, sometimes it's positive, is more access to teletherapy, right? Lots of people are offering teletherapy who weren't before. Oftentimes it's more affordable because insurance companies are covering it, or covering, you know, at least in Michigan, they're covering co-pays for a while. So that's great. There's so much we don't know about kids and their mental health and socialization, but we know that that's been really challenging for a lot of young people. There's this kind of, I've heard it referred to like preemptive survivor's guilt for those who are able to stay home and isolate and feeling guilty and ashamed that they are able to do that, even though other people are not, because they don't have a diagnosis or because they're considered essential. It can be really triggering. This is where social media and the news comes in for people who can't leave home and they see others trying to go back to normal. So having weddings and going to the movies or the gym, flying on vacation, all of those things can really create this us versus them dichotomy. There's certainly caution fatigue, right? As like we're entering month 6 of this, like people are like, do I still have to be this careful? But if I'm not, what comes up for me? Should I just give up? And that can trigger a lot of mental health things. And also the impact, a lot of medical spaces are not allowing a support person to come in. You have to go in by yourself. So for disabled people, not having a support person or advocate to be able to help out during medical procedures can really challenge mental health as well. In residential treatment spaces, and to be clear, these are coming from actual people who have been in residential treatment spaces, so psychiatric wards and other things during COVID, is that many of the measures that everybody touts as preventing the spread of COVID can also be seen as suicide risks. So in a lot of these residential treatment programs, masks are not allowed because they're considered a suicide risk, and hand sanitizer is guarded and rationed because it's seen as a suicide risk. So on one hand, we have constantly, please sanitize your hands, wear a mask, do all of this, but also you don't have access to these things if you want to get treatment for your mental health or mental illness. Patients who have mental health diagnoses are often blamed for having those blamed for their COVID anxiety. So this is a direct quote from a person in a program. Their provider said to them, "You're only worried so much about COVID because you're mentally ill," which is crap. Because I think lots of people with and without mental illness have incredible rates of anxiety about COVID. There's also less options for programs. Some programs are not taking people in or taking them in smaller quantities, obviously for spacing and social distancing, but that means people might have to choose to enter programs that feel less supportive to them or not go to the program, which means their mental illness or mental health continues to get exacerbated. Congregate treatment spaces, so these are like nursing homes, residential care facilities. I think we have all heard, especially starting in Washington, but everywhere in New York and much of the East Coast, is this incredible rate of spread through nursing homes and residential care spaces. Then there's also, because of that spread, they're really banning any visitors. Some places are just having the same nursing team stay all the time. So people are feeling really isolated there. They're not able to see their friends, their families, their community members. A lot of folks are having to go into congregate care spaces because there's this big challenge in getting personal attendants and personal care attendants. If you're someone who's chronically ill and you need a personal care attendant who's not going out and seeing other people, right? Many PAs work for multiple people or work multiple jobs, or especially work as in a healthcare setting, and then also as a PA. And so people are having trouble finding PAs, or are having to let go of PAs that they used and liked because they're also going to the hospital and increase their COVID risk. And so if people can't get access to PAs and PCAs, it means they have challenges with independent living and then are more likely to join into congregate care settings. And what this does is really shine a light on the existing issues of this societal idea of we just warehouse people, both older folks and those with disabilities, rather than support them in living in their own home and home spaces. For deaf and hard of hearing folks, masks, I think many of us have heard these conversations, make it way more complicated to hear. I know I am not deaf or hard of hearing and have trouble hearing people when they speak with their masks sometimes, and are near impossible to lip read. They are now making, you can buy them, they're more expensive, masks that have a clear window, but we don't know if that makes them less effective, and they're also still not perfect for lip reading because the lips are distorted. A lot of the rules regarding one person at a time in stores and hospital settings elsewhere makes having someone's interpreter impossible or very challenging, or they might be asked to use a different technology that they're not as familiar with. Captioning with online meeting platforms. I just taught my first 2 classes this week and I was so excited. has the beta testing of Zoom for captions, which is great. It's also like inaccurate about 30% of the time. It's not always used by people. I also learned 2 nights ago that when you break out into breakout rooms, captions are not available in breakout rooms. And what I've been hearing from a lot of deaf and hard of hearing folks is that there's a huge lag. So even when captions are working and are accurate, they're still like 10 to 15 seconds behind what's happening, which makes it really hard for people to participate in meetings, in classes, etc. There's also this improper use of the ADA. So folks don't really know often what the American Disabilities Act does, and it does not mean that you can hand somebody a placard. These placards don't actually exist. They are made up by people to prove that you deserve some sort of accommodations. So first of all, I want to be clear that accommodations are not something that somebody deserves or not. It is a basic right, is what the ADA says. And in this case, it means it's kind of that a business could ask you to come in at a different time for an appointment only. They could ask you to do curbside pickup. They could give you a personal shopper and you give them a list and they go take care of all of those things. But again, this anti-mask rhetoric is actually making it really hard for people who actually cannot wear a mask. So due to panic attacks or neuralgia, pain. And it also perpetuates this really challenging faking it narrative that a lot of disabled and chronically ill folks already face, right? You don't look disabled. I don't see you as disabled. So clearly you don't, quote, deserve those accommodations. And this creates, again, this tension of like, these folks, many of them with these placards are actually faking. They're using this as a loophole. But we also don't want to perpetuate a faking it narrative because disabled people are not faking it and should be able to access what they need. There's sometimes, special hours for older folks and folks with disabilities is great, and it can be really positive, but first of all, it's very early in the day, so a lot of people with chronic illness, who are the people who would need these hours, cannot get up for a 7 a.m. Grocery shopping hour. But also it leads to this policing of bodies, so especially those with non-apparent disabilities. So if I was to try and go during that time, I'd have to make sure I brought my cane and all of this. And even in that case, sometimes the greeters are like, this is actually only for older folks. I have a friend who's pregnant and she wanted to make sure I named that. She's 8 months pregnant and tried to go to one of these early hours at Whole Foods and was told multiple times that it's not for people like her. Even though legally in the US, pregnancy is considered a disability and she also is chronically ill. There's issues with getting legally required accommodations, so at-home workspaces and related needs. I'm really lucky that Michigan allowed me to buy, for those who can see, this fancy comfy chair, so I'm not using a kitchen chair at home. But not everybody is able to get that and get what they need to be able to work effectively at home. There's not always the flexibility that people need. This idea that, well, you're at home now, so of course you should be able to make this time and do these things. And we still, as schools are just starting to go back, we don't know how we're going to support kids in school settings with 504 IEPs. So disabled, neurodivergent children, chronically ill children, how are we ensuring that they are getting the care and education they need while also not increasing risk of spread of COVID? There's this big push for socially distanced spaces, which is awesome, but especially now, the summer and the outside, a lot of these spaces are not as physically accessible. So if we're telling people to go to parks, a lot of parks, don't have wheelchair paths in them. There's often a lack of seating and a lack of shade when people are trying to connect with people. Being outside can be really hard for those with heat sensitivity, such as POTS, which I have, and I have just been inside all the time. If you have allergies, mast cell activation syndrome. So while many people are out and about during the summer being like, this is great and we're socially distanced, again, it creates this further level of isolation by not being able to participate in those ways. Also, outdoor signs in parks, on hiking trails, et cetera, often don't have Braille, which makes them inaccessible to blind individuals. And a lot of outdoor activities are inherently inaccessible or can be accessible, but require a lot of planning and a lot of funding. So things like kayaking, hiking, boating, swimming in the ocean, et cetera, may need accommodations to make them accessible, and those are not always available, especially right now. We also, with elections coming up, employment, kind of some of these social problems, chronically ill folks are already who have jobs that aren't supporting this work from home model or who are requiring them to go in person are having to quit their jobs for safety so that they don't get sick. And they have to make a choice between, can I pay my bills or can I not get COVID? A lot of disabled people are already in low paying frontline jobs. So thinking about grocery store baggers, department store greeters who are required to be there and they're at higher risk. A lot of Social Security disability insurance hearings have been put on hold or are still delayed significantly, meaning that people are having to do with less money. They can't take a job because they're trying to show that they can't work a job, but also they don't have their hearing to know whether they are going to get SSDI funding for themselves. And as far as the election, a huge portion of disabled and chronically ill people rely on absentee and mail-in voting to vote, and always have. And even more so now, it's not safe for many of them, many of us, to vote in person. And there's a lot of political rhetoric about how, quote, dangerous mail-in voting is. And if mail-in voting, if absentee voting is not allowed in the November election, then a lot of disabled folks will not be able to vote and really lose that way to have themselves heard. This is a lot of content to try and get in an hour, so I hope I'm doing okay. So I'm going to switch to a moment to LGBTQIA2S individuals and communities. So what's shown is the Progress Pride flag. So it has rainbow colors horizontally, and then there's kind of like an arrow coming in from the side that has the black and brown stripe, which recognizes queer and trans people of color, and then also the blue, pink, and white that represents the trans flag. So what is included in this community is lesbian, gay, bisexual, and pansexual, transgender and non-binary, queer and questioning, intersex and asexual and aromantic, two-spirit, and other non-cisgender, non-heterosexual identities. You'll note that I also go back and forth between LGBTQIA2S+ and queer and trans, which are both about the same amount of time to say. It's really hard to assess prevalence because the census doesn't ask any questions about gender identity or sexual orientation. And the BIRFIS, which is the behavioral survey that's given in every state, some states ask it, very few do, some states don't. So estimates, we don't know very much, but somewhere between 4 and 15% of the US population fall into this kind of alphabet soup, if you will. And a lot of that depends on how identities are conceptualized. So non-binary people for a very long time have never been included in any of these surveys, but the 2015 United States Trans Survey, which had, I think, 27,000 respondents, found that a third of their respondents identified as non-binary, yet almost no mechanisms for collecting data at a state or federal level include the word non-binary. And so that's why some of these numbers are pretty all over the place. So there's been a huge impact on transgender and non-binary folks around their gender affirmation. So there an incredible amount of people have had their gender affirming surgeries delayed or canceled. So these are people looking for top surgeries, either to have breast tissue removed or breast tissue added, having bottom surgeries, having hysterectomies, oophorectomies, vaginoplasties, all of these things which are not considered essential surgeries, but for the mental health of this community, they absolutely are essential surgeries. And you can imagine how somebody is excited, looking forward to something, getting ready, has everything set up, and then now it's like indefinitely postponed, and that can be a huge, huge issue. Trouble getting access to hormones. So again, there have been some shortages, supply chain and transit issues. Also, right before the pandemic happened, for example, Michigan scheduled testosterone as a controlled substance, and other states are doing that. So now to get a regular supply, you have to go to your PCP on a regular basis, which is much more difficult right now. And again, these are things you can't often do like automatic refills on. So that means more pharmacy visits. It means you can't stock up on like a 3-month or 6-month prescription like people suggested you should. And that's really challenging. And not having access to hormones within even like one missed dose can start changing things, and that can trigger gender dysphoria for folks, anxiety, depression, etc. This might seem inconsequential, but it's huge. It's a lack of haircuts that affirm gender. So especially for transmasculine people, being able to have shorter hair, for many, not all, is an important part of their presentation and what affirms their gender and helps reduce gender dysphoria. And with a lack of access to haircuts, especially for several months in hotspots and states that did not allow that. There's actually a group that was getting together and raising money to send buzzers, like hair cutting tools, I don't know the official term, to young trans folks who didn't have access to them to make sure that that was something they were able to do during this. A lot of people are getting misread and misgendered with their mask on. So misgendered is when, so I told you all I use she and her pronouns, and if somebody came up to me and was like, oh, good day, sir, right? Now for me, because I am not trans and I don't have gender dysphoria, I might be like, okay, well, I'm presenting femininely. I don't know where that came from, but okay, right? Or I might just correct them. But for a trans person, particularly someone for whom being seen as their authentic gender is incredibly important, being misgendered can trigger huge mental health issues, cycles of thinking about what's wrong with me, all of those things. And so having the masks on, people are less likely to see facial hair someone's grown, lipstick that people might put on to, like, you know, imply to someone that, look, I'm not a sir type of thing, and other things that we code as gendered. So that's been happening a lot. Safety is a huge issue. So young people who are queer or trans might not be out to their families, and they're having to move back home because of economic reasons, colleges shutting down, etc. And so they might have to, as a young trans person, have to be misgendered constantly, wear clothing that does not feel valid to them, and so on, maybe not be able to talk about their partners. Even if they are out, their families might not be affirming and could actually be emotionally and physically harmful and abusive. And misgendering is a huge microaggression, and it is violence. So that can be really harmful to folks who are having to do that. We already know that trans and non-binary people experience incredible high rates of intimate partner violence, particularly compared to their cisgender or non-transgender counterparts. And now they're going to have less access to support and exit strategies because it's not as easy to say, oh, I'm going to go couch surf with my friend until I can get back on my feet. There's less jobs. More people are saying we can't have people inside my pod or bubble. Some shelters are closing down. A lot of LGBTQIA2S people participate in sex work, and now they have less options for safer practices and harm reduction, right? Less call-ins, that type of thing. So might be resorting to more dangerous types of sex work. And it also means fewer clients. And this is across all types of sex work. I talked to some folks who are strippers and are like, well, as strip clubs have shut down, like I have to choose, am I going to do a type of more full service sex work, or do I, you know, I can set up an OnlyFans page, but now everybody's setting up OnlyFans pages, and like it's really creating lowered income. And then anybody who works in the sexuality field, whether it's sex work or even people who work at like sex toy stores, have not been able to file for unemployment. Also, domestic violence and intimate partner violence shelters are less likely to be open now, or also be enforcing social distancing, so have lower numbers of people they can take in. And queer and trans individuals then have less choice about which shelters to go to, and might have to go to a shelter that's less affirming around who they are, and they might be placed, for example, as a trans masculine person, be placed with women because they have an F on their driver's license, which can then cause more trauma. Mental health, and I know someone spoke about this a bit earlier or yesterday maybe, but just a few things that I wanted to note. A lot of this community is built on connection. So the loss of physical spaces and events like Pride has been devastating. Pride for a lot of people is the first time they're able to come out or be around folks. For those who are in unsupportive work environments, unsupportive family spaces, unsupported homes, being able to come out and be with other people that have similar identities and experiences is really uplifting. And queer family, chosen family, trans family, it's more than family of origin, family of birth. And so, you know, I mean, I have a whole article coming out about the concept of chosen family in queer spaces. So I can't like distill this down into one sentence, but not being able to connect with people outside of your pod or bubble really has a huge impact. Even for those who are living with supportive families, not being able to have that community connection can feel really isolating. Asexual and aromantic individuals are less likely to have partners, especially live-in partners. And so they are experiencing even higher rates of isolation because their pod might just be themselves. Again, a positive is more teletherapy. More access to teletherapy means that people in areas with no gender affirming therapists can get better quality care. So like here in Michigan, we have the Lower Peninsula and the Upper Peninsula, the UP. And in the UP, at least currently, there are no mental health professionals who advertise as supporting trans clients at all. It's not on anybody's website. There's no support groups. There's nothing for that. So many trans folks up there either have to come down to the Lower Peninsula. Some of them drive like 5 hours to get basic care and even mental health care. So the fact that there's telehealth is folks in rural areas or more conservative areas may be able to get really affirming mental health care. So that is a positive. And similarly, a lot of prides went virtual this summer, and other LGBTQIA2S affirming events went virtual. So people who are in rural areas or conservative areas who might not have ever been able to go to a pride or an event like that are able to attend. And similarly, right, here's that intersection of where I was talking before, is disabled LGBTQIA2S plus folks who might never have been able to go to Pride because it's too hot, because it's inaccessible, because all of those things, because it causes a panic attack, or sensory issues, are able to go to these events and spaces from the comfort of their home. They can mute things, they can use captions, etc. LGBTQIA2S folks are already more likely, and especially trans and non-binary folks, to be or underemployed. So they're already in a financially precarious position before this. And recent studies out of, I believe, Williams Institute, cited in my references, said the Black LGBTQ individuals are experiencing incredibly high rates of economic impact, which again makes sense because racism plus ableism, right, they stack. This community is also more likely to experience food insecurity and homelessness already. And again, it's even higher amongst trans and non-binary folks, but it's true for anybody not heterosexual. And then this is then further exacerbated by COVID, reduced resources. And for those who are experiencing homelessness, this push towards making fun, socially distanced spaces where people are putting all the tables out onto the sidewalks and closing streets off has really pushed gentrification in these areas, and also pushed a lot of homeless individuals out of their spaces where they are comfortable and feel safe, where they have created their own communities. And also sometimes their belongings are confiscated during these kind of like rebrands. Transphobia means that trans and non-binary individuals who are maybe at unsupportive workplaces will be the first to be let go or furloughed compared to their cisgender peers who don't experience transphobia. But there is a positive. So historically, trans and non-binary people have experienced a lot of voter suppression because they might have a mismatch. So I might look like this because I'm a woman, but my ID says I'm a male. And if somebody feels like that's a mismatch, I might not be able to vote or be requested to cast a provisional ballot, which may or may not be counted. And so the ability to vote via mail and absentee voting reduces or even eliminates this problem. So here's something combining disability and queer and trans issues that's really come out of this that is a beautiful positive, and that is the bigger acceptance, support of, and like push for mutual aid and community care. So mutual aid really arose from communities of color and disabled communities. And it's this idea of like, what I have to offer, I can give to you, and what you have to offer, you can give to me. And it doesn't need to be like necessarily like a one-to-one exchange. Like if everybody feels like they can offer what they can, then like that's just as meaningful. So that's really beautiful. Individuals, communities coming together to share resources, lift each other up. A lot of like towns or counties have like a mutual care list, mutual aid or community care list, where people are offering things from, I have an extra thing of wipes, can I drop those off for you? Or I'm growing grocery shopping, do you wanna, can I pick things up for you? I have things in my garden, can I share those? For a lot of college students all having to move out at the same time. I know here in the Ypsilanti and Ann Arbor area, a lot of people were offering storage because people had to move out of their houses, campus housing so quickly. So even though it has taken this really horrific international health crisis to get here, it's beautiful to see this outpouring of support and compassion. And there have been, these movements have in some areas been co-opted and have resulted in ableist and racist rhetoric, and also the prioritizing and supporting of white and non-disabled people. And so, if somebody's like, I need rubbing alcohol for hand sanitizer, and somebody's like, I need rubbing alcohol so that I can give myself my like medically necessary shots, and it goes to the person who just wants to make their own hand sanitizer, you can imagine the impact of that as someone to say like, my like physical well-being is not as important as someone like creating something when they could be using soap. Right? So with that, oh, beautiful. We have 11 minutes for questions.
Yes, that was wonderful.
319 of them. Holy cow.
That's right. Don't worry. I've distilled them down into a few key points.
Awesome.
Yeah. So thank you so much. I want to say actually one of the most common things that I saw in the question box was students saying thank you. Students who have disabilities, students who have parents that have disabilities, and also students who did not know about these issues, as well as, you know, members of the LGBTQ plus community, all saying thank you to you for this talk. So I want to reiterate that. Thank you so much. And a few points of clarity. Students were asking about a few of the terms that you used. ASL is American Sign Language. Teletherapy and telehealth are virtual ways to get therapy or health appointments. Also, could you clarify neurodiverse, what's included in that, as well as two-spirited?
Yeah, absolutely. So neurodiverse or neurodivergent are used by folks that are not neurotypical, right? So I'll come back. I know I'm like, don't explain a term with a term. So that includes folks who are autistic, folks with ADHD, OCD, whose ways their brain works is different than the way we have established as the, quote, right way for a brain to work. And hopefully we all know that there's lots of ways brain works, right? But for example, as a neurodivergent person myself, I get sensory overload really easily. I go on tangents really easily, as my students will often tell you. I have special interest in, like, if you ask me about like British murder mysteries or the WWE, like I will like download information called info dumping, right? So it's someone whose brain works a little bit differently than how we've socially decided a brain works.
Got it. And two-spirited.
Oh, two-spirit, yes. So two-spirit, excuse me, is a indigenous term. It was created actually by the indigenous community, essentially for colonizers, if you will. There, as hopefully you know, in North America, there are an incredible amount of tribes of Native folks. And so some tribes really supported folks who are not cisgender. Some tribes had a third gender, some tribes had 4 genders. So the Diné, the Navajo, had 4 genders and were really affirming of someone who did not fit into this easy man-woman category. And actually, a lot of them were upheld as healers, as connectors. Wiwa was actually like the emissary, the ambassador to Washington. And so there's a lot. Two-spirit encompasses both sexual orientation and gender identity. And with all of these different tribes having different ways of looking at things, people who are not indigenous came in and said, use some really harmful terms, like prostitute was how they referred to these people. And so I think it was 1990, 1991, a group of indigenous and First Peoples came together and said, let's come up with one term that encompasses all of this so that people don't make up their own terms for us. And that's where two-spirit came from. So you cannot be two-spirit if you are not indigenous. It is an indigenous specific term.
Yeah, that's great. And I think that's really good clarity. That's something that we talk about in anthropology a lot. So I've heard about that since the beginning of, I guess, my higher education, but I think it's still something that a lot of people aren't familiar with. So just a couple more clarifying points. Chronic illness, what all is included in that? Because some students are asking about things like asthma or hypertension, HIV, and then related to that, because that was included within what could be considered a disability. So related to that, is disability an identity? Like, does a person identify as disabled, or is there some other way that it's determined?
Yeah, great questions. I'm also just looking through this list of questions. I wish I had a whole semester to talk about this. So chronic illness, so some things like a question, and I'm going to put this all together. So there is disability as defined from a medical model, which is like the very traditional model. Remember I said something about a social model, which is where society is creating things. And then there's now also these integrative models, right? Because I might say like, I'm depressed, and like, if society was more supportive, my depression would be more under control, but I also might want support around it from a medical perspective, right? Like, better living through pharmaceutical chemistry. And so there's space for both. Some of the things you named, like for example, HIV is officially included under the ADA as a disability. And anxiety is included as a disability. Things like hypertension, chronic kidney disease, those types of things, it really depends. And similar to the way that we have trouble asking around gender identity and sexual orientation, the way the census asks about disability is different than how getting Social Security disability insurance asks about disability, which is different than if you were to ask me my identity, right? And so some people with disabilities don't include that with their identity. And that really comes from more of this person first approach, right? They're like, I'm this person and I happen to have this disability, but it's not my identity, right? But there's something really beautiful in disability community. And one of the reasons I've actually been able to be okay at all during this pandemic is because I have been so connected and plugged in with disability community for so long. And so even before this, if I was having a fibromyalgia flare, or a panic attack or, multi-day migraine and couldn't show up physically in a space, like my disabled community, we have group texts, we have all virtual table gaming simulators, even before the pandemic, right? And so I was already plugged in and connected to this community. And to me, as someone who has community around something, just like I have queer community, right? I have Jewish community, I also have disability community. And so that's part of my identity. But it's not true for everyone. And I see a lot of people being like, how would you know what language somebody uses, right? And here's the thing, is ask them. And this should be for everything, not just because you see someone is disabled, but like asking someone like, hey, what language do you use to describe yourself, right? Like, how do you see yourself? And it might change in different spaces, right? Like, I realized I forgot to put fat on this definition because like this didn't feel like an activist space, but you better believe it. Like in my classroom, I talk about I'm fat and then students ask questions and we talk about health at every size. We talk about validating our bodies, right? So yeah, I don't know if that answered it, but.
It does. And I'm glad you touched, because I was going to ask you about the, how do you know if it's identity first or person first? So I'm glad that you touched on that. And also, I mean, I think the way that at the end you were also talking about the intersections of all of these things, how important that is. A lot of students had questions about that. And I think one question related to that is students want to try and understand, why does it feel like we have these social movements right now to try and draw attention to other marginalized groups, but it feels like ableism is not something that's talked about that much?
I mean, that is 100% accurate. I would say ageism and sizeism are probably the two, and I own that those are identities that I hold myself, and so biased in that way. But those, I think, are identities that are often relegated to the back of the burner, right? With sizeism, a lot of it is because Michigan is actually the only state in the country that has non-discrimination based on weight. And even then it happens, but right, but I think disability, because it's not seen as an identity, because it's seen as a separate piece and something that's bad, problematic, to be fixed, to go away, and historically always has, right? Like parents want to fix their children. My child doesn't have this. Like, what surgeries can we do to fix this? But if we move towards a framework of saying like disability is part of our natural diversity, and like, for example, my anxiety and my OCD is how I am able to be as productive and as effective as an academic as I am. If I wasn't like able to sit down and write a whole paper in 8 hours, like, I don't know if I would be able to be an academic, right? And so how do we look at these things as, but yeah, please bring up ableism in spaces. I have several articles that are written about ableism in higher education, ableism in social work programs and all of that. But I promise you, if you yourself are disabled, if you have disabled friends, which I know you do, even if you don't know that, they might not feel comfortable telling you yet. If you start being the person who always asks in meetings, hey, can you turn the captions on? Hey, can we be a little bit more flexible about ways that people show up in this space? I guarantee you that people in your circles will be so appreciative, because I love it when I'm not the only person being like, actually, like, can we not all go on a hike for the first day of class? Because that's not fair to everybody's body.
That's excellent. Students have also been asking about what they can do, and I think that's great advice about what they can do to help with this situation. And yeah, I just personally got anxiety from you talking about how quickly you write a paper, which I already know because your publication list is amazing. And I encourage students to check it out. Related to that, so students want to know generally, but then also a lot of students that are pre-med want to know what they should keep in mind in the future when they're caring for patients who have a disability, or for trans and non-binary patients. What do you recommend advice for pre-med students to be thinking about as they go through their training?
Oh my gosh, I love you already. Well, first of all, we just published a paper called the Trans Inclusive Provider Scale, which was trans and non-binary people in Michigan created a list of like, these are the things that would make a provider inclusive. And then we did statistical analysis of it. So that's in the American Journal of Preventative Medicine. And these are like basic things like share your pronouns with your patients, have a blank for gender on your intake form, make sure you've taken a trans 101, make sure your office staff know these things, like use people's correct names. All of those things are like very basic, but it's a great checklist if you're new to this. I would say as far as around disability, like honestly, so I do disability activism all the time. And it wasn't until I had a neurologist out here in Michigan who I walked in, and the PA who took me back was like, do you want me to turn the lights down so you don't have this like bright glaring light above your head right now? And I was like, that's an option? Like, I never had even thought to ask that. So even asking patients when they come in, like, what can I do to make this space more comfortable for you? And lots of people are going to say nothing, and that's fine. But someone might say something like, actually, could you have, like, I would love it if you could have a chair that doesn't have arms because it's easier for me to get in and out of. Or, hey, is it possible for me to bring my partner next time because they help make sure they take notes? Is it possible for me to take notes or to record this on my phone? So making offers around that. And here is the believe people. This is across the board. If someone tells you, like, and we know that especially Black and brown people and women and feminine presenting people, physicians do not believe their pain. They do not believe their disability and their reality. I had a student of mine who was trying to get into a neurologist because she was having headaches for months, a Latina student, and nothing, they put her on like a 10-month wait list to see a neurologist. They told her to take Tylenol. She finally went to the ED and they found a brain tumor. She's having surgery in 2 weeks. And like, no one listened to her. So when people tell you, like, when I'm like, I have a 6-week migraine, like, listen to someone. When someone says something like, I have a panic attack from wearing a mask, instead of being like, well, everybody gets anxious from wearing a mask, help them troubleshoot that, right? Like, and the same goes for trans folks. If somebody's like, hey, I am non-binary, but I want to have top surgery, or I'm non-binary, but I want to take estrogen, that is not your space to be like, well, non-binary people don't do hormones. Of course they do. People do all sorts of things, right? So the more that you can listen to and trust your patients, the more that they will be honest with you, and the more that they'll come back, and then they'll also listen to what you're telling them to do. Because when we feel like we're like at odds, or like, I think I'm from Colorado, right? It's like two rams batting their heads with a physician or any medical professional, it's really hard for me to build rapport. But it, like, my new neurologist here, like, walked in and was, you know, heard my whole background and was like, wow, that's a lot. Like, that must be really challenging. Are you doing okay? Like, it's the first time I've ever in my life had a physician ask me if I'm doing okay. You know, so now I'm on my soapbox, but like, really, this goes for any profession. Social workers, I tell them all the time, right? Like, what can I do to support you is like, for everybody, like, imprint that in your brain. What can I do to support you? The answer might be, you know, can you dim the light? The answer might be, can you help me find a good therapist? The answer might be for, you know, if you're working in a coffee shop and someone's struggling, like, I can't see, I'm feeling sensory overwhelmed. And you might be like, oh, cool, I have some extra headphones, or there's a space in the corner that is a little quieter, right? So when we ask people what they need, people feel comfortable sharing that.
That's excellent advice. Everything you've told us today, I think, is really helpful and gives us a good roadmap for what we can be doing to help. We are actually over time, and I know that you're very busy, so I don't want to keep you, but if you have any other thoughts or parting words, I guess I'll say, that's probably not a good expression to use, but any last words that you'd like to tell the class before you go?
I mean, I think all of this distills down, and not just around disability and queer and trans identities, but around race, around age, around country of origin, around size. All of this is that the more that we can make space for people to show up as their authentic selves, and that we can listen to them and hear them. And like, activism doesn't have to be marching in the streets. We know this from disability justice movements, right? It can be sharing things that are written by disabled people and queer people and trans people, and especially all those folks of color. It can be, you know, simple as like switching your meetings to Google Meet so you can have captions if your Zoom doesn't have captions. It can be simply telling someone, I believe you, and I'm here to like listen to what you have to say. You don't have to be perfect in any of the work you do, but you do have to keep trying. And the more you try and that you listen and you get better, then the better our society becomes and we move forward.
Thank you so much. That's excellent advice. I really appreciate you taking the time to talk to all of us. Thank you.
Is it possible for you to send me these questions?
I will. Yep,
okay.
Absolutely. We
Awesome.
download them.
They're such good questions. Thank you all for being so engaged. Please take care and have a wonderful rest of your educational adventure.
Thank you so much. Bye. Okay, great. So we are now moving into the second hour of class, and we are actually going to start with a brief student education. I keep telling everyone to make sure that they vote, and it turns out, as we just heard, that that is additionally complicated this year, as I've mentioned before. And so we'll just take a couple minutes for this, let's call it a public service announcement. All right, welcome.
Hi, everyone. Thank you so much, Professor Milich, for having me and for letting me talk to the class. And thank you for introducing us to Dr. Kattari. I think a lot of what she said resonated with a lot of us, and it definitely kind of opened my eyes. We're currently plotting in our group chat how to steal her from Milich, so that's exciting. Let me just try to screen share my screen. Okay. And then I'm just going to... Okay, so hopefully you guys can see this. My name is Rita Qureshi. I'm an incoming freshman. I am majoring in anthropology, and I'm working with an organization called Campus Compact on their Safe Elections project. And the goal of the Safe Elections project is to address the national poll worker shortage that this pandemic has caused. And so one of the overarching messages throughout Professor Milich's lecture series has been that the best tangible way that we as students can actually do our part in the pandemic and address some of its detrimental effects has been voting in officials that will take public health as a priority. However, with mail-in ballot voting delays, in-person voting is really some people's only option when it comes to voting, and there's one really large complication to that, and that is the national poll worker shortage. And so in terms of what exactly that poll worker shortage means and its extent, we see here in this little graph that 56% of all poll workers are over the age of 60. And we know from this class and from just reading in the news and whatnot that it's this age group that is most vulnerable to contracting COVID-19. And it's the poll workers, in fact, who are in charge of, and they're also called election judges or inspectors. They're in charge of issuing ballots, registering voters, monitoring equipment, answering questions, and sorting ballots so that they can be properly counted. However, because nearly 60% of all poll workers are above the age of 60, a lot of them aren't returning to poll work. It's just too dangerous for them. And so as a result, we are seeing a lot of states with huge poll worker shortages in the thousands. And this adds up, of course, to a poll worker shortage in the millions. DC, for example, lost 1,700 election workers. 95% of all past poll workers in Anchorage, Alaska, refused to work the polls this year. And Kentucky actually consolidated their in-person voting to one polling place per county. And that was because they were so afraid of this shortage here. In Georgia, there were hour-long wait times just to vote. And the effects of this have been pretty disastrous, not only for the country at large, but for specifically people of color. We've talked a lot about in this class how the pandemic has affected people of color. And when it comes to voting, a lot of POC fill jobs that we deem essential, and they can't afford to be waiting an entire day in polling lines just to check a couple boxes and exercise a constitutional right? And this also, of course, applies to people of color that are at a greater risk of contracting COVID because of pre-existing conditions that complicate the situation, and they can't afford to be waiting in long lines with a bunch of people for an extended period of time. This also applies, as Dr. Kattari said, to people with disabilities, people that physically cannot stand in line that long, or because of anxiety reasons can't be in a crowd that large for that long. So this is, of course, why we need students to step up and work the polls. Some perks of becoming a poll worker. Oh, this was just a slide on how it does disenfranchise people of color. And then some perks of becoming a poll worker are that it is a paid position, so you get paid for a full day's work. And WashU will likely excuse the absence. I will work on getting that confirmed for you guys. And also you'll be protecting democracy, so I think that gets you bragging rights. And then, as Dr. Kattari said, a lot of the time people that are voting in person have difficulty voting because their gender identity or their personal identity doesn't match what's on their government ID. And so having younger people working these polls may in fact, benefit those people who do generally have trouble voting in person. And then some good news for out-of-state students like myself is that it's perfectly legal to vote in Missouri and to register to vote in Missouri, which is a requirement to become a poll worker in St. Louis County. So this is assuming that we're still on campus in November. If you want to become a poll worker in St. Louis County, you have to be registered to vote anywhere in Missouri. You have to declare a political affiliation, and that's because they like to have an equal number of Republicans and Democrats running the polls. And then you also have to attend a quick training session. And so just to register to vote in Missouri, you just have to update your registration to 6515 Wydown Boulevard with your MSC campus box number as well. If you forget to include your campus box number, there's a possibility your ballot will be sent to the post office on campus and then sent back to the Election Commission, and your voter registration as a whole will be canceled. So you want to be sure to include your PO box number. And make sure you keep in mind that the registration deadline for Missouri is October 7th. So you want to go and change that. How do you change that? You can go to wustel.turbovote.org and you will be able to change all your information on there. If you want to become a poll worker, you'll go to powerthepolls.org/campus. The /campus is there because it's helping Campus Compact keep an eye on how many people are actually signing up and how effective is their initiative. And then if you want to stay in the loop with some more information, or if you ever have any questions, you want to DM me or some of the upperclassmen that are working on this, you can DM at WashU Poll Workers on Instagram. So that is everything I had.
Wonderful. Thank you very much.
Thank you for having me.
Of course. Thank you. All right. So we are going to keep moving along with the next portion of our, Megan, can you please give me screen sharing rights? Thank you. I think is what I need to do. Wait, maybe I can do this. Okay, I'm on it. Sorry about that, Megan. Okay, so the rest of our lecture is going to be a lecture by me. Again, you get to see so much of me this week. So on the syllabus, you'll see that today we're talking about markets. I want to use this as an opportunity to talk some about markets, some about things that we've been talking about in the class already. So I want to say, can someone raise their hand if everyone can see and hear me? But I know I'll get, like a million. Okay, we're good. Thanks so much for raising your hand. Okay, so we have been talking about SARS-CoV-2 and COVID-19, and so we are going to be talking a little bit about some of the things that we have already touched on. So far, you have completed 17 out of the 30 hours of lectures, so congratulations, you are past the halfway point. We're making great progress in this course. I hope that you're learning a lot and you still have a lot of great things to learn. Of course, this is our class, The Pandemic, Science and Society. And so we're talking about the intersections of these two things by having experts talk to us about different aspects of both the science and society. Now, keep in mind that we're now halfway through and the first half was a little more focused on the science, but as you saw, there are intersections of these things, right? So being focused on the science does also mean that we're going to be talking about society. And in the same way, moving forward, as we talk about society, there will be references to the science because within this pandemic, they intersect. So I want to talk a little bit then about the design of the course. You may be feeling like now that you've gone through half of this course, your experience and what you're learning and what we're talking about isn't the same as what you've experienced watching the news or talking to your family. And that makes sense because this is a class. It is based on experts who are leaders in their field talking to you about specialized topics that are related to COVID-19. That is different than what you might see in the news or what you might talk about with your family because, for example, in the US, our news focuses on having a fair and balanced perspective on different opinions. And there is a place for that sort of discussion and debate. But when we're talking about a virus, a medical issue that has a scientific facts behind it, has societal relevance, what we need are people who are informed about the data and can talk to us about information that is correct. Because as we've covered in this class, there's been a lot of misinformation circulating. And so naturally, what you are exposed to in this class is going to differ from what you see on the news. And that's true of any science class that you take. So let's take, for example, when I teach about evolution. When I teach about evolution, when I bring in guests for that, I never bring in guests that are talking about how evolution doesn't exist, because that's not useful information for the students, right? Instead, it's important that students get information from individuals who understand evolution and can talk to them about evolution. And there's lots of things to debate in evolution, but there isn't equal time given to people who do not understand evolution. Similarly, with climate change, that's something that gets talked about in the news a lot. What you hear in the news about climate change is naturally going to differ from if you take a class in the geology department on climate change, because the information that you will be provided is based on informed data collection from experts. And that's what you should be expecting. When you come to a university and you're able to take a class, you should be expecting that sort of knowledgeable information. Okay, so if I can get my slides to work. So when I was thinking of putting together this course, I thought about who are the leaders in the field in terms of knowing about COVID-19, knowing about SARS-CoV-2, dealing with this pandemic, right? And I'm approaching this from a US perspective. So I want to ask you, if you had been me and you were asked to take on this course, who would have been the first person that you reached out to? Who would have been the person that you thought, this is a person that can talk about this pandemic? And you can go ahead and put your answers in the Q&A box. Okay, I'm seeing a lot of answers coming in. And okay, there's one for Bill Nye, but overwhelmingly, also someone's mom, but I don't know who your mother is. Okay, so aside from Bill Nye and a person's mother, Dr. Fauci, Anthony Fauci, Tony Fauci, those are all the names that came up. So I appreciate that. Like, when we're talking about this course, it makes sense that the person that you would think of, that you would want to hear from in this course, is Dr. Anthony Fauci. So when I was asked to teach this course, the first email I sent was to Dr. Anthony Fauci. I told him all about the class. At that point, we didn't have an enrollment yet, so I couldn't tell him how many of you there were. But I told him about the class. I told him I would love for him to speak to the class. And of course that I've followed his work for years, because I have. He's a very important person in the field. And I decided that I wouldn't ask anyone else to speak to the class until I heard back from him, because of course he would be the key person. Fortunately, it took him very little time to get back to me. Within the hour, I had a response. And unfortunately, you may imagine, he is a pretty busy person right now. And so he was unavailable to talk to this class. I'm sure he is regretting it now that he knows how great it is, but I tried. So based on that, you now can kind of see the thought process that I went through when I asked people. I looked at who were leaders in the field, who really stood out as understanding the science, understanding the societal impacts, and I asked them if they could be a part of the course. And as you've seen, we've gotten very important, influential people who are leading the way in terms of how to deal with a public health crisis, understanding viruses, and this pandemic in particular. So we've heard in the news, you may have heard about this being talked about as the great equalizer. And yet we've heard from our experts about how, in fact, this is not the great equalizer, right? There are many ways in which there is nothing equal about this. People are being affected in very different ways. And so I want to continue to talk through just a little bit about this information that you hear in the news and then what you're learning in this course. Because one thing that you should be able to do is take what you're learning in this course and apply it to what you're hearing in the news or from your family members, etc. There's a question that I've gotten a few times in this class that is, why is COVID impacting Democratic states more than Republican states? So let's dive into that. That's something that you should be learning to assess. You should be learning how to answer that question in this course, right? Okay, so let's look at the data. Now, when you say Democratic states or Republican states, there are a few different ways that you could interpret that. This is a map of the presidential election. This is the way the Electoral College went, right? So this isn't popular vote. Electoral College of the 2016 presidential election, we roughly group states by being red or blue. So all the states that are featured in red went to Trump. All the states that are featured in blue went to Hillary Clinton. And the map obviously has a lot of red on it. There's a lot of red states where the Electoral College went to Trump, and of course, he was elected our president. You could also think about this in terms of state level government. So this map on the left is a map of the governors of a certain state and whether they are Democrat in blue or Republican in red. And you'll see that this is very similar. There's more blue on this one, but a lot of the states stay the same. So California is still blue, Texas still red, Florida still red, New York still blue, things like that. There's some overlap. But in order to answer this question, we need to be specific about what we're asking. Since I don't know for sure, I'm just gonna show you the data as they exist for these two maps. All right, so this morning I went to CDC and I pulled some different maps that they have of COVID cases in the US right now. So I'm gonna show you a series of maps, and down at the bottom, I put our two color-coded maps of the Republican and Democratic states. So I've reversed the order here, but on the left is the presidential election from 2016. On the right is the governor's map. So this first one is the total number of COVID-19 cases in the US reported to the CDC as of this morning. And the darker orange color is the higher number. I'll orient you to which ones are darker orange. And so here we have California, Texas, and Florida are the three darkest states. California, Texas, and Florida. Oh, and Georgia, I'm sorry. California, Texas, Florida, and Georgia are the darkest states. And if you look down at these maps, in both the presidential map and the governor's map, California is blue, so it's a Democratic state. Texas, Florida, and Georgia are red on both maps. So here we have one Democratic state, three Republican states. So already that question of why are Democratic states more impacted isn't being supported by the data. Here we have the US COVID-19 cases reported to the CDC in the last 7 days. So this isn't total number of cases, it's the last 7 days. And now Georgia is not one of the highest. Instead, we still have California, still Texas, and still Florida are the ones reporting the highest cases right now. Now again, California, Democratic, Texas, and Florida, Republican. Okay, so that still doesn't fit with that question. But then we can look at per capita. So how many people live in these states? COVID-19 case rates in the US reported to the CDC per 100,000 people. And here it shifts a little. All of a sudden, California falls out as being one of the highest rated, and Texas actually falls off a little bit also, not as much as, it's not as light in color as California. Florida still and Georgia remain bright orange colors, right? So when we look through these data from the CDC, we find that this question that was asked, apologies, going back to it, why is COVID impacting Democratic states more than Republican states? We find a flaw even in the basis of that question, right? And so one thing that you should be able to do in this class is use the information that you're gathering to assess the things that you're hearing. Now, something that you've heard from some of our speakers is the fact that points of entry were majorly hit through COVID spread from international locations, right? What are some major points of entry in the US? New York City, is a major point of entry, which we've talked about. Atlanta, Georgia is also a major point of entry from outside flights to the United States. So I think that, you know, using what you're learning in this class to think about the information that you're getting from outside is really important. Okay, so again, this class is based on asking experts in their field to talk to us about the work that they're doing and how it relates to COVID-19. Fundamentally, that means that it will be different than what you see in the news, although as we've already seen, some of our speakers are often featured in the news as well. But what you should be getting from this class are tools for evaluating the situation, tools for being able to look at policies, for statements people make, reading the literature, and being able to critique it and take away important information for yourself. Another goal of the course that I think has come out as speakers have been talking is that in order for us to appropriately deal with this pandemic, judgment is not useful. So speakers have talked to us over and over again about being kind, about like not placing stigma on people, things like this. And so in order for us to get out of the situation we're in, the goal is not to place judgment on individuals, but rather to work together to find a solution to reduce transmission and to get to a better state. And part of this includes the fact that words matter. The words that we use matter. They matter in where we're putting our effort. And so I'm going to talk to you a little bit as we talk about markets, about words and word choice. And I think that that's something that also came up in Dr. Kattari's lecture. Okay, so let's talk about markets. Something that I'm sure you've been hearing is this international call to close wet markets in China. As we heard from Dr. Wang, it is likely that it was at a market that this initial transmission from a non-human animal to a human occurred. So there's this call to close wet markets. We should then know what a wet market is, right? And make sure that we're closing what we think we're closing. Several of our speakers have referred to farmers markets in the US. For those of you who don't know, a farmers market is an open air market where vendors, individual vendors sell food that they've grown or that they've produced themselves. It's got a positive connotation generally in the United States. It's part of kind of the farm to table movement. It's also all about individuals being able to, you know, support their own farm businesses themselves and that sort of thing. And so generally we think of this as positive. And yet in this course, you've heard multiple speakers talk about how wet markets are very similar to farmers markets. So I want to dive into that a little more because again, this is a difference in how we're judging things, the words that we're using, the value that we're placing on different terms. So a market. A market is a regular gathering place for the purchase and sale of provisions, livestock, and other commodities. In the US, we commonly think of the supermarket, which is also a market, right? That's the market that we go to purchase most of our provisions. Anvil Head, who hopefully you all now know and love, she has a favorite market. She has a store that she likes to go to and pick out treats. They have a whole table where they make fresh treats and they set them out, and she would eat them all if she had the choice. But that store, like many stores in the US, has regular business hours. They close at night, but Anvil Head doesn't care. So she always insists on going over to the store, and then she sits, as you can see, outside of the store. She walks up, the doors are locked. I can pull on them and show her they're locked and say they're closed. And she's like, that's fine, let's break in anyway. You can set her leash down and walk away, and she still just sits there like a forlorn puppy dog, wanting to break into the store to steal her treats. So we all have our markets that we like, Anvil Head included. And I'm sure it won't surprise most of you that I enjoy farmers markets. Even during this pandemic time, I've been doing my no contact delivery from the Tower Grove Farmers Market in St. Louis, which is one of these classic farmers markets. It's open air. It's not the only farmers market in St. Louis. There are lots of there are some famous farmers markets in St. Louis. But you know, they're vendors with stalls. They sell vegetables, fruit, eggs, meat, coffee, things like that. I also go to a market like this in Uganda. So this is a picture of the Mpanga market where I buy my vegetables and fruit and eggs in Uganda. They also sell fish and meat. They also sell, as you can see in the middle picture in the background, there are cooking pots there. They sell all sorts of things at these markets. So these sorts of open air markets where you can buy fruit and vegetables, eggs, fish, etc., they're common around the world. They're common. And they're also common in China. So this type of market is a wet market in China. It's a place where you can go to buy your fruits, your vegetables, your meat, your seafood. That's a wet market. And I go to markets like that frequently, right? Some of these wet markets in China also sell and slaughter live animals, so things like chicken and fish. And to be honest, we have markets like that here as well. And then more rarely, there are wet markets in China that sell wild animals and wild animal meat. That's important. So keep in mind that not all wet markets do that. But these ones that sell the wild animals and the wild animal meat are more appropriately called wildlife markets. And that's what people that are studying these sorts of issues call them, wildlife markets. It's important to differentiate that a wet market does not necessarily mean a wildlife market. And if we are trying to control the spread of zoonotic diseases, then the words we're using matter in order to shut down the proper types of markets. So wildlife markets exist in other countries too, and they're legal. I mean, they've been legal in China up until this outbreak, and they're legal in other countries as well. An example from the US are seafood markets, right? So like we have such a negative image. I think many of us have this very negative image about wet markets in China. And then you think about seafood markets in the US, and it's a totally different image that you get. So I looked up this article on seafood markets, and I found this article that had this really great picture, right? Like this place looks super cool. It's not at all the type of negative stereotype that I've been told about wet markets in China. And in the article, it says, Pike Place Fish Market in Seattle, Washington is the best seafood market. And it says it's also the most fun. All right, let's look at this place. So I look them up. Look at this. We've got wild caught fish being flung across a space. All of these people standing around, this is obviously pre-COVID time, watching, taking pictures, laughing. This is a great time, right? Look at these. This person having a wonderful time, children right there taking pictures. Here are 4 people together, standing close together to catch this fish. It's not even just about fish. There's also other kinds of seafood. This person having a really great time with these crab legs, I guess. I'm a vegetarian. I think those are crab legs. Okay, so I mean, we need to keep in mind that we may not totally understand the situation and that it's very important to understand what the problem is so that we can find the solution. So does China need to close all wet markets? There has been this big outcry, close all the wet markets in China. But the reality is that China does not need to close all of the wet markets because zoonotic disease transmission is coming from wildlife markets. Wet markets in China are providing food for people. I mean, this is where people go to buy the food that they need to eat, right? Closing all of them would be a very serious endeavor when what we need to do is close wildlife markets because it is the wildlife markets that are actually presenting the concern. And in fact, China has placed a ban on people trading or eating wild animals right now. It's important to note that that ban is temporary, so we're not sure how long that will last. And that they are supposed to be coming up with a new legal framework for this, though it's not released yet. And you probably will not be surprised that there has already been economic and social pressure for there not to be a ban on wildlife trade in China. And that is very complicated. I'll try and get into some of that right now. So the international wildlife trade China and beyond is a multi-billion-dollar business. This is serious. This isn't just some random people going out and killing a bat or something. In China, there are millions of farmers that rely, China and around the world, there are millions of farmers that rely on this business, and they were doing it legally up until recently. So you can imagine you're a corn farmer and you've had this business for a long time, and all of a sudden what you do is not legal. That's complicated. So completely banning this way of life is complex. It's not as straightforward as we would like to think. And it requires us to think about how to do this well. So this is something that I deal with a lot in my work. I believe that if we want to improve conditions for wildlife, for human health, for the environment, we have to actually do it in a way that is feasible. And I mentioned to you on the first day of class that I do work with communities in Uganda. That work is called Conservation to Coexist. It's a participatory action research program for wildlife conservation and human health and well-being. And it's because where I work, there is a national park that has lots of endangered species in it that are also very damaging to human crops. And they also present the issue of potentially passing zoonotic diseases between wildlife, humans, and domesticated animals. So you have a rainforest that goes right up against small subsistence farms where people are living off of the food that they're farming. And if you say to them, look, when that elephant comes and tramples all of your food and you have nothing to feed your children and they're starving, don't kill it. That's not reasonable, right? If you want to place a ban or you want to have certain rules, you need to create a situation in which it's feasible. Because what people are worried about right now with the wildlife markets in China is if you do this ban and there are all these people that are relying on it, to what extent is illegal trade going to increase? I mean, it already exists, but to what extent is it going to increase? And how can we stop that from happening? Because what we actually care about is stopping the problem, right? We want to stop the interaction between humans and wildlife that lead to zoonotic disease transmission. How we do that needs to be mindful. We can't just put a ban on it and think that we fix the problem. So, you know, the issue in Uganda that I'm talking about is different than the issue of the China wildlife ban, but it's related. I want you to be thinking about how you have to actually come up with a solution. So what we did here is we talked to people about making changes along the boundary of the park so that they wouldn't have these interactions with animals. Animals wouldn't come out and eat the food that they were growing. And one way that you can do that is by digging these ditches along the boundary of the park. We call them trenches, and they're very deep and steep, and elephants cannot cross them. And a lot of animals can cross them, like baboons, for example, but they make it more difficult. The issue is that an elephant is very smart. It will walk up to the edge of this trench and just kick dirt in until it can get across. And they do that all the time. So in order for these trenches to be effective, you have to maintain them. So we needed people to actively engage in maintaining these trenches for the good of their own crops. But of course, you can't dig a trench everywhere. You can't dig a trench in a swamp, and there's lots of swampy areas around rainforests. But instead, we realized that elephants were also afraid of the sound of bees. And so if we could put beehives across the swamps, then we could keep the elephants out of the swamps, and we could also keep them out of crossing where it was dry. So we could create like this barrier that elephants wouldn't cross. So we started creating these, what we call beehive fences, where it's beehives attached to wire. So in the background here, if I can get my pointer to work, in the background here, this is going down a hill, these beehive fences that are crossing here, the trench is connected up here. And we have these groups of people, this is me, this is a really grainy photo, sorry, who go out and work on maintaining the apiaries, work on maintaining the trenches. And we also had them start growing garlic as a cash crop, because it turns out that garlic is unpalatable. I mean, if you're a cook, you know that's just nonsense because garlic is so delicious, but it's considered unpalatable to wildlife, so they don't eat it, and then you can sell your garlic, you can sell the garlic seeds, and so on. And so we gave people an actual plan for how to avoid interacting for wildlife, for how to improve their own health and well-being, that allowed them to follow the rules of not killing endangered species, right? And I think that thinking about this process and being thoughtful about it is so important. And it is key to our own health, because if we want to stop these sorts of pandemics from happening in the future, then we actually need there to be ways that these things are handled that are effective. I also want you to keep in mind that it is not only food that is the issue for wildlife trade. Global health is threatened by wildlife trade that includes exotic pet industry. I think for the US, this is a big point right now because a lot of you may have watched a show called Tiger King over this quarantine period. I'm sure no one will be shocked to know that I did not watch Tiger King, so I don't know exactly what happens in it, but I do know that it is related to the exotic pet industry. And that industry is absolutely a way that we could have zoonotic disease transmission. It is something that we should all be concerned about and should not be supporting. There's also other products that are made from wildlife. So it's not just about people eating wildlife that is a concern. And not to mention that, you know, we need to be thinking about how we're interacting with our environment overall. And we're going to get into that in the next lecture. So I want to remind you that words matter. And a couple other words that I think are relevant about this topic of wildlife trade and wildlife markets is the term poaching. So when I first started learning about conservation, people always used the word poaching, poachers, poaching. And so I used to use that word. And it's very common, and I think that it's also problematic because what we're doing is taking something that is considered fine in many places, hunting, and putting a negative connotation to it, poaching, right? So I think one of the most clear examples of this for me was that one time in Uganda when I was hanging out with my field assistants, my research assistants, we were having lunch or whatever in the forest, and I was talking about we just tell stories about our families. My family hunts. I mean, I don't, but a lot of people in my family do, and they fish. That's been something, you know, my family in Slovakia does it. My family in the US does it. I come from a hunting family, let's say, if that can be an identity. And so I was talking about my family hunting, and they hunt all sorts of things. And the research assistants were really shocked by this. They said, so your family members are poachers? And I said, no, it's legal. It's okay because it's legal. And they were like, well, what do they hunt? And I said, oh, well, a lot of different things, but you know, there's this one thing, it's a white-tailed deer. It's really common where I'm from. And they said, what does that look like? And I said, you know, it looks a lot like a Ugandan cob. So these are Ugandan cobs. And white-tailed deers look a lot like them, in addition to the fact that there's another species that lives in the forest called a bushbuck, and white-tailed deers look a lot like a bushbuck also. These are things that people in Uganda are not allowed to hunt. And so the research assistants felt very uncomfortable with the fact that they were finding out that this person they've done research with for years was a poacher or, you know, related to poachers. And that really put into perspective for me, like, I can talk about legal and illegal hunting, but this term poaching has a lot of history to it and is very problematic. Similarly, bushmeat. Bushmeat is a term that is really problematic. And so as you hear me talking in this lecture and the next one about illegal wildlife trafficking, illegal hunting, wild animal meat, wildlife meat, those are the terms I'll be using because your words matter and these types of words are problematic. I also want to point out that it is not just with wildlife that we have to worry about zoonotic disease transmission. This has come up for multiple speakers, and I think that it's already been discussed, the fact that we have zoonotic diseases that come from farmed animals. So we also need to be thinking about our agricultural systems and how those lead to disease. You know, this summer, if you live in the US or Canada, this summer, you may have heard about this huge onion recall. This is a news article from just a couple weeks ago from Business Insider that says at least 979 people have been infected with salmonella, that's linked to onions sold at grocery stores, right? Sold at supermarkets. So these are onions that you can get in the supermarket. So it's not a matter of just, oh, I can get a disease if I go to a farmer's market, or I can get a disease if I go to a wet market. The way that we interact with the natural world, the way that we produce food is sometimes problematic. And so you can get these diseases, you can come into contact with pathogens in a lot of different places where we get our food, in a lot of different markets. So, you know, I'll just note that salmonella is a bacteria and not a virus. But on the first day of class, when I was talking to you about how emerging infectious diseases come out of our interactions with the natural world, bacteria is very much a part of it also, right? So it's not just viruses, it's not just bacteria, it's not just parasites. I mean, it's all of these things combined. And you know, I travel a lot, I'm in remote places a lot, so I've had a lot of infectious diseases, and I would say so far, I should knock on wood or something, the most serious infectious diseases that I've had have not been viruses. So I've had malaria multiple times, I've had Shigella, I've had typhoid fever despite having had a vaccine. It was an older vaccine. Anyway, I've had bad infectious diseases, and you know, that's not, they haven't been, the worst ones that I haven't been viruses, but all of these different zoonotic diseases are a concern because of how we interact with the natural world. So I just want to wrap up by saying, remember that your words matter. I've talked to you so many times about being conscientious of your wording, being conscientious of how you interact with each other. Please make sure you continue to do that. Remember that human-wildlife interactions can lead to zoonotic disease transmission, so we need to be thinking about that in all aspects of how we expose humans and wildlife to each other. And also that our interactions with the natural environment can impact future pandemics, and I have to be continued because that's what we're going to be talking about tomorrow. So I still have a few minutes to attempt to read some of these questions, of which there are many. So let's see what we have here. Lots of people still voting for Dr. Fauci, which I totally agree. Okay, so the term bushmeat, a lot of people have asked about the term bushmeat, so even though it's slightly off topic, I'll talk about it. So bushmeat actually originated specifically to Africa, right? And was meant to be part of this like wildlife that you could get in the bush, quote unquote, also a problematic term. And so it was meat that you could get in that way. But now people often use bushmeat as a term to describe wildlife meat. So like if you hunt a monkey in the Amazon, some people call that bushmeat, even though technically that's not where the term comes from. And so, yeah, there's negative connotations, obviously. Okay, so there's a question about, are there plans to work to regulate wildlife markets and wildlife trade in order to curb zoonotic transmission without causing significant economic hardship or an increase in illegal trade? That's exactly what people are trying to work for, right? So there's been a lot of information coming out about how do we actually do this? What systems need put in place in order for this to happen effectively? And it's extremely complicated. I mean, you take a multi-billion-dollar business like this, and there's not going to be a quick and easy solution. I think if we have to look at positives that came out of this pandemic, one positive is that this has drawn so much attention to this issue. And as I have said in this class before, this pandemic is something that people were concerned about and talking about and waiting to arrive, and no one was listening. Nobody that really could make an important decision about it was listening, right? And I mean, a lot of people who have been working on this issue have said that COVID-19 is basically the single best thing that has happened to trying to stop wildlife trade in China. Because you took an issue that like for so long people had been fighting for to try and get it to stop, and very quickly there was suddenly a ban on wildlife trade. And that was shocking to people in my field who have been working on that for decades and longer. So yeah, this COVID-19, the pandemic, the reality of the situation that we are in definitely is something that we, that is a concern that has been worked on for a long time, and suddenly we have a reason that people are paying attention, and so we need to use that for our own good. Okay. So what if the community isn't receptive to solving these problems? I'm really glad someone asked this. So the idea with participatory action research and community-based research, things like that, are that the community has to be involved. They have to be the ones driving these decisions. And the reason that I do this project in Uganda is because community members came to me and asked me to do it. So I had been working with monkeys in Uganda for a long time. And then maybe, I don't know, 7 or so years ago, people came to me and asked me specifically if I would help with this issue, which is such a key for anyone who's looking to do this type of work, working with communities or solving problems in any way. Make yourself available to hear what they need, because so many people go to other places, they decide what the problem is, they decide what the solution is. It fails miserably sometimes, and in other times it makes the local people there feel really bad about themselves, because the message that you're sending by doing that is not as good as you think it is. So I think that being in a situation where you can help communities do what they need to do works really well. It's worked great for this project. And, the reality is that when there's a problem, when people are suffering, they know it. I mean, we are not somehow like uniquely able to see disparity and see issues and come up with a solution. Like, not at all. People who need help, they know what the problem is, they probably know how to fix it, and they might just need someone who has a different set of skills to help them deal with that. And my particular set of skills is grant writing. So I was able to write the grants that fund the work that creates that community project. And so, you also probably have a skill that could help a community. But just keep in mind that that skill is not necessarily solving the problem or being their savior. That seems like a really soapboxy note to end on, but it's a good piece of information for all of you, especially because every class you're asking the question of what can I do to help? So really, that's a very important point, is don't assume that you know better than the community that you're trying to help. And as Dr. Kattari was saying, ask people what they need, ask people what you can do, and then you can really be helpful. So with that, we are finished with today. Tomorrow we will be talking, you'll be listening to me again talk about the environment in COVID-19, and then we will have an excellent talk on workers' rights and the law. So a bit of a shift, talking to a professor from the law school. So I will see you all tomorrow. Until then, stay safe.